Welcome to Prescription Health, a Tabula Rasa healthcare podcast. Prescription Health addresses the evolution of healthcare by focusing on news, developments, and predicted growth in value-based care models, including PACE. Join us every month for insightful conversations with subject matter experts by subscribing or visiting us at tabularasahealthcare.com/podcasts.
Hello and namaste, everyone. I am Dr. Ankur Patel, Chief Medical Officer at Tabula Rasa Healthcare and author of the book, Age is Just a Number. Welcome to the episode of Prescription Health, our newly expanded podcast formerly known as Keep Up with Pace. I'll be serving as your moderator for today's episode. We'll be discussing pharmacogenomics. I'm excited to introduce my panel. I have Dr. Devin Fox, Vice President, Clinical Operation at Immanuel in Omaha, Nebraska. Dr. Adriana DeJesus, she is a geriatric pharmacist and clinical manager of pharmacogenomics at Tabula Rasa Healthcare, and Dr. Eric Glantz, medical director at Beacon of Life in New Jersey. Namaste, panel, and welcome to Prescription Health.
Thank you for having me.
So much
Thanks for having me today.
So before we start the podcast, can you please introduce yourself briefly about your organization and your role within the organization? We will start with Dr. Fox.
Hi, Ankur. Thanks for the invitation. It's an honor to be able to participate in the podcast. My name is Devin Fox. I'm an internist based out of Omaha, Nebraska. I'm the Vice President of Clinical Services for Immanuel, which is a geriatric services company based out of Omaha with a footprint from Iowa and across Nebraska. We actually have senior living service lines as well, including skilled nursing, memory care, assisted living, and independent, as well as PACE. And we have 3 PACE clinics, one in Des Moines, one in Lincoln, Nebraska, and one in Omaha, Nebraska, each one with 3 providers. 2 of them have a physician and 2 nurse practitioners this time, and one of them has 3 nurse practitioners, and we're kind of always looking at the best models to explore for team-based care. And so we're in the midst of exploring some options going forward.
That's awesome. And how many participants you have in total?
Just about 210 at each of our centers. So just over 600 total across the organization.
That's awesome. Adriana?
Thank you, Dr. Patel, for the introduction. As mentioned, I'm Adriana DeJesus, and I'm the manager of Pharmacogenomics at Tabula Rasa Healthcare. I'm responsible for leading our PGx Clinical and Coordination Center, where we facilitate our PGx services for healthcare providers and patients.
Okay, and also tell me, Adriana, can correct me if I'm wrong, you also did a residency in PGx, is that correct?
I joined Tabula Rasa in 2017. Actually, my residency program did not focus on pharmacogenomics, but as soon as I concluded my residency program, then it was all pharmacogenomics training from there on out.
Nice. So she is somebody who specializes in pharmacogenomics. Eric? Dr. Glantz.
Yes, thank you so much. Super excited to be here and to talk about this topic. I am the medical director for a Beacon of Life program with 2 sites in New Jersey, where I've been for the last year and a half. One site has been around for about 8 years with 280 participants. The second site has been open for about a year and has about 70 participants.
Congratulations on your new site. It's always excited to see PACE growing, and especially New Jersey. Devin, nothing against you, but we have a powerhouse from New Jersey today.
Love that.
So, Adriana, let me start with you. PGx, pharmacogenomics, sounds very fancy. But if you have to explain in simple language, what is pharmacogenomics?
It's a great question. So pharmacogenomics, or PGx, is what I'll refer to it as throughout the talk. It essentially helps us gain a better understanding of the way genes may influence our response to certain medications.
Okay. And how does it work?
So there are genes that code for drug metabolizing enzymes, And these enzymes have a range of activity or expression. And based on that expression, a phenotype is assigned. Now, it's going to depend on the enzyme that we're talking about, but in general, phenotypes could be poor, intermediate, normal, rapid, and ultra-rapid metabolizer. So, as an example, if we had a patient who was a poor metabolizer taking drug X, this patient wouldn't have enzyme activity. So they wouldn't be able to break down that drug. That leads to that drug building up in the body and increasing the risk for side effects. And the opposite would occur if we had a patient who was an ultra-rapid metabolizer who has increased activity and is breaking down that drug a lot faster, leading to a risk for therapeutic failure. Now, these examples are, again, if we're talking about a drug that is therapeutically active. If we are giving a drug that needs to be activated, then the opposite would occur, right? Poor metabolizer, no enzyme activity. You can't activate that drug, so your risk is therapeutic failure. And then ultra rapid, you're activating the drug very fast, so your risk is for side effects.
Okay, so sometimes, like if I'm taking a pill and the gene and receptor and drug doesn't match, there could be chances that I'm taking a medication and I'm getting only 50% of the benefit, and possibly another 50% could be the side effect of the medication?
It could be. It's going to depend on which phenotype that we're talking about, but exactly.
Okay, thank you. So I wonder, Dr. Fox, do you guys use PGx at your PACE organization?
We do. We actually are in the midst of kind of a trial of it across all of our participants. We worked with Geriatric year and a half, 2 years ago after I learned some more about PGx and had some conversations with you folks, and kind of engaged in a conversation around how it could look for us to over a period of time test every one of our participants. And so we ended up taking a pretty aggressive approach where we ended up with a per member per month number that would allow us to test each and every one of our participants over a certain period of time. And the pacing of that was kind of up to the clinic, the center, and then Geriatric on the other end who processes the labs. But we are now about 18 months into that, and we have tested probably just over about half of our participants. And I think we're going to talk a little bit more about this later, but the stratified according to some of the things that I think you're going to.
No, I'm definitely. We'll go and talk about more what you have done. So, Dr. Glantz, do you guys use PGx at your center?
Yes, we do use it. PACE in general is designed to take care of the most complex patients out there, and with complexity of medical conditions, comorbidities comes polypharmacy, patients on a lot of medications, so we have started using PGx as a way to, really accomplish what a lot of people in medicine are trying to accomplish, and that is, trying to work smarter and not harder.
Yeah. And And so do you how do you pick a patient at your PACE organization? Do medical director usually pick the patient, or your pharmacy, in your case, care kinesis pharmacists help you pick the patients?
Yeah, so it's definitely a collaboration between providers or myself and the clinical pharmacists. Generally every month we have polypharmacy meetings that go over, certain participants, whether the new ones joining or ones that are on a lot of medications. Or sometimes simply we just have a participant who is having a lot of falls, or we just can't control their blood pressure or their depression or certain conditions. So that's when we may initiate, PGx test to, open up some, information of how to have better outcomes.
Okay, so Dr. Fox, how normally does it go? So let's say you and your pharmacist decide this patient will get the PGx test, you get the kit. Then what happens to your end? How does the process look like?
Well, so we actually set up a pretty good process. So basically, being a heavily nurse practitioner driven clinic, we did kind of have an algorithm that stratified people according to if they're on certain medications, if they're on, if they have a high fall rate, if they have a handful of things before we just open the floodgates to test everyone. And so we had them, upon enrollment and upon periodic assessment, consider whether this person at that time would be an appropriate individual to undergo the testing.
Okay.
And then when it proceeded.
And then once you get the test kit, does the provider normally swap the patient, follow the instruction, and send the kit back?
The nurses have been doing that.
Nurses has been doing that. Okay. And so Adriana, from you as a pharmacist end, how does it look when the kit is ordered? So you guys send the kit gets there, they do their side of the test, the kit makes gap. And how long usually it takes to get the results?
We expect to receive results within 2 weeks.
Okay.
After our vendor receives that specimen.
And then once you get in 2 weeks, how does it look on the back end? Like who sits there and reviews the results? And because I also think that when you have the results, now you will be also looking at the patient's medication list.
Yeah, exactly. So initially when we receive results, one of our PGx specialized pharmacists will compare the PGx results with that participant's complete medication regimen. So we're the ones that are initially developing a report that addresses any drug-gene interactions based on the PGx results alone. We also incorporate drug-drug gene interactions, so phenoconversion, which we can touch upon. We include clinical guidance, and then we hand this report off to one of the pharmacists who are collaborating very closely with either Dr. Glantz or Dr. Fox's team. And they're the ones who also incorporate patient-specific factors and develop personalized recommendations to the clinician. So we support the providers the entire step. We don't just give results and then it's up to you all to figure that out on your own. So our pharmacists support it.
Okay. So Dr. Glantz, what happens on your side when you get a call from the pharmacist, the results are in, these are the medication list, and these are the recommendation? What happens from, like, provider normally follows the instruction, or what happens on your side?
So there's really a couple of steps involved in actually making this into a realistic process in general. When it comes to medications, generally patients, especially if they've been on them for a long time, it does take some kind of initial education. This is what this test is, what we're trying to accomplish, and the potential benefit of it. So that seed has to be planted initially, because when it comes to incorporate any type of recommendations, with the patient, at least they kind of know what's going on. When we get the recommendations after the PGx results come back, generally how we do it, we have a meeting with the PGx team or clinical pharmacist to go over the findings, talk about what are the 3, 4, 5 recommendations, make this change the time of this medication. And then once we have something tangible, then I can go back to the participant and kind of have a meaningful conversation, so that when it comes to take away X medication, it's everyone's on the same team. They're part of the care plan, not that, Dr. Glantz is trying to take away this medication.
Correct.
So there is a little bit of art to this, but part of the success is the collaboration with the clinical pharmacist and their ability to get that piece. They know that it's not so simple. So that's really been helpful.
And Devin, me and you have been in a pace for a long time now, and we know there's always a barrier when it comes to implementing something. In this case, so when the result comes in, and either it's convincing your provider to order it and then implementing it, and then the second challenge is patient who agrees. What do you see on your end?
I think Eric hit the nail on the head. It's the education on what the plan is and what the purpose of the testing is from the get-go. When someone's identified as a good candidate, or like I said, for us, we're kind of trialing utilization of it across the board. But at least to explain that what we're doing is what formerly had been called precision medicine or whatever, and what we kind of are confident that is going to find its way into best practice in the future, and that it's going to help identify potentially medications that are unsafe or we're not getting the most benefit out of. And so it's all about explaining that from step one. And so we have spent a lot of time with our providers and trained them up on that. And another thing that I think we'll get more savvy with over time is our own understanding of the results as they come in. It's tremendous to have the collaboration with the pharmacist and everything like that. But I think to be able to refer back to it, review it with the patient one-on-one, the participant, and continue to explain and educate on the purpose of it and why it's impacting what we do. Because another thing I like about it is, in combination with MedRise Risk Score and some of the other tools that you guys have to offer, is you can even do theoretical med substitutions in the future in light of what we know about their PGx. And so that was really what tipped it over to me, is to say, what if we think about switching from this to this? What would that do? And so I'm anticipating and looking forward to finding out if our theories play out to be true, that's effective.
So Adriana, from your side, now once the PGx test is done, we have it on the record. Is it something that it's almost permanent, or after a few years you have to repeat the test?
We don't have to repeat it. We treat it like we would a lab value. So it's incorporated into the patient's clinical decision support. So our pharmacists are able to reference that information anytime we're doing order verification, or during one of those polypharmacy calls or any type of clinical initiative. That's another component that our pharmacists consider when intervening on a patient.
Okay. So is it fair to say that all the time when a new order is put in by a provider, a pharmacist on the back end will be reviewing the medication, drug-drug interaction, how this will work with the PGx, because they already have the results on file?
That's correct. That's the expectation, that pharmacists are also considering this information.
Okay.
Yes.
And then is all PGx the same, or your PGx at Care Kinesis is different than others that are there in the market?
When receiving PGx information, typically you'll receive a report that includes just your genetic results. So gene, genotype, and what that phenotype is. There's going to be some reports that also consider any potential drug-gene interactions. So they may list out a lot of medications and highlight which ones might be appropriate or ones to stay away from. But what's unique about our PGx services is that we have access to the participant's complete drug regimen, so prescription and even OTC. And we're able to take it a step further and also account for any drug-drug gene interactions that result in phenoconversion, so that we're not going to see outside of.
Oh, really? Okay.
Services.
So for the audience, to make it simple, so the one is the drug and gene. And what you just mentioned is like the drug gene, which is the phenoconversion. So that means is this test is looking at multi-drugs, like a drug, 2 drugs, 3 drugs interaction among themselves and with the genes.
Right, yeah.
So that also kind of, it's kind of, we always joke, but sometimes taking the right medication on the wrong time is not helpful.
Right.
Okay. So now when we talk about, starting it, and as a provider, it's like, and even at CAP meeting, NPA, all the providers, when we talk about pharmacogenomics, it's good. But when we come back home and then we are like, we don't know where to start. So what are some suggestions or recommendation, Adriana, you want to give to the medical director that, this is the place to start?
So, and I think Dr. Fox alluded to this, right? So if we're interested in testing all participants, who do we target? How do we prioritize? We're looking to see, which drugs have PGx guidance available that would lead us to make a change to therapy. And we have three major buckets that we
Okay.
target. So the first one would be clopidogrel. So that's an antiplatelet. It has a lot of PGx guidance available, even research studies for years. And we target that medication. We then focus on opioids that are activated by CYP2D6. And then we also target certain antidepressants. So those are the three buckets that we'll prioritize.
Okay, so coming to that point, Dr. Fox, there was a study done at your program, and it targeted those three medication that Adriana mentioned. Do you want to share how was that study, and we can talk more about the results?
So that's a good question. That's what we're kind of awaiting, because we have anecdotal information. Really, two of those three things, you end up with subjective information back from your participant. And we have anecdotal information of better mood disorder outcomes with adjustments based on PGx testing, as well as some one-offs of what appears to be better pain control with what we're understanding from it. Right now, we're in a phase where we're kind of looking at more process measures. And so what I can share is I think we're at about 85 to 90% acceptance rate of the recommendations coming in from the CK pharmacist. And so at least we have a lot of data to say that we are integrating the recommended suggested medication changes. And so then we're kind of sitting back and we'll see what that translates into.
Okay, there's some trends in. Adriana, do you want to share some?
Yeah, I have some preliminary findings from about half of the participants that have completed testing. So based on the results, we've identified about 80% of participants have a drug-gene interaction, and about 50% of those participants experience phenoconversion. We took it a step further, too, to see what opportunities the pharmacist would have to suggest a change to an alternative medication. And we can target 40% of those participants to make a change. So it's pretty meaningful that our pharmacists can make actionable recommendations here.
So that's a big number when we are talking about 80% of the participants who were tested and they have some kind of a drug-gene interaction. Because that also takes us to me thinking about, from always we assume, or what I call preference-based medicine, right? So as a provider, these are my preference for SSRIs. These are my preference for possibly opioids. And so actually this kind of a result will help me move from preference-based medicine to precision-based medicine. Eric, you had some studies done at your and at your program, you picked opioid, if I'm correct?
Yes, that is correct. Yeah, we had a fantastic opioid study that we did. Really motivated by the, big theme and topic across all medicine, that is, the opioid epidemic, and certainly in general, trying to achieve pain control for our participants in light of, sensitivity of prescribing opioids, which is always a challenge for most prescribers in general. So we initiated an opioid study to become smarter with our prescribing and also to achieve better pain scores and outcomes for our participants.
So in your study, and I was just looking at the results, it also shows that the pain score did decrease on patients that got PGx and with the recommendation that was followed.
Yes, absolutely.
Okay. So this is more something down the road you will be also looking at how you can expand this service more further.
Definitely, yeah. So I think, again, opioids is pain medication is a low-hanging fruit area where we often struggle to control patients' pain. So having the additional knowledge of which medication would achieve better outcomes or, what medications are interacting with each other really helps to achieve better outcomes and smarter prescribing.
Yeah. So I think what I'm hearing is definitely it's valuable. A lot of time we ask a question, where to start? And I think going back to Dr. Fox's program or Dr. Glantz's program, starting with the lowest hanging fruit, opioids, antidepressant, clopidogrel, Plavix. I also tried it more on antipsychotic. I think those are the good baseline to start. I remember a funny story. Dr. Mike Brett, who is now on the capstone side, but he was the medical director in a PACE program in Pittsburgh. And I remember him telling me, "Oh, I was one of the first initiator to do PGx." And once he got the hold, he swabbed all his 300 participants. And moving forward, whoever comes in gets swabbed first. So he's like, I'm eliminating adverse drug event from the get-go. And what he told me was I was surprised that he said out of the 300 patients, only two patients has a so-called normal gene. That doesn't mean everybody were abnormal, but normal that you can give any medication, it will work accordingly. But other patients, he mentioned that pretty much had some kind of, drug gene interaction that they had to make adjustments. So the question was like, how do you implement those adjustments there? And to the audience, a lot of time we are talking about adverse drug event. If you have not heard, it always comes out that if adverse drug event was a disease, it's the fourth leading cause of death. And these are the things that we could prevent. So when you are in your falls committee meeting, when you are in your inequality improve meeting, when you're on your polypharmacy call, these are the things. Let your pharmacist know, and they will help you out that how you can implement that, because there is a huge opportunity to deprescribe medication, especially like Plavix, decrease or deprescribe any other medication that possibly might be causing the adverse drug event. So these are the opportunity that I want you to move forward. At least think about it. Talk to your pharmacist, because we want to improve patient care. And we are in a risk-based model as well. So that also helps. So we have been talking about, Adriana, about this, but can you explain phenoconversion in brief?
PGx is just one of the many pieces of the puzzle that we need to consider when working up a patient. So PGx helps us identify drug-gene interactions, but there are other external factors that also may influence our response to certain medications. And our primary external factor that our pharmacists are focused on are other drugs that the patient is prescribed. Now, these other medications may lead to drug-induced phenoconversion. And phenoconversion is essentially a mismatch between someone's genetically derived phenotype and their actual capacity to break down or activate a medication. Imagine if you were in a parking lot and it's full. You have to wait your turn in order to park, right? Until
always
a
happens
space becomes
at the
available.
local Wegman. Yes, go ahead.
So if you had somebody who was a normal metabolizer, you would expect a typical response of drug X. If you were also taking drug Y, which has a greater affinity to bind to that enzyme or to take that parking spot, then that drug X needs to wait its turn. So you would have the buildup of that drug X leading to increased risk for side effects. So this scenario is mimicking someone who would have been categorized as an intermediate or a poor metabolizer. So these other factors are important for us to consider as well.
Sure. Devin, do you think now, like, especially when we are thinking about race-based diagnosis, treatment, we assume some genetic assumptions, especially now in America, when you think about us Americans being a big melting pot, do you think PGx is underutilized?
I'd say it probably is. I mean, a lot of our assumptions based on any of the ethnic-driven outcomes and things like that we have found may not be grounded in truth. If you look back at recent information on sickle cell occurrence in African men, it doesn't necessarily track. And so we need evidence to prove that our assumptions are true. And this is an area that's pretty black and white. And I do see PGx and other pharmacogenomic testing integrating more into the approach of the care of any patient.
Sure. Eric, do you see much, a lot of time now you are getting some positive outcomes. You might want to increase your PGx testing in your center. Do you see any barriers implementing PGx in your center?
So, I mean, certainly, biggest barrier from a, provider standpoint is just the education, learning the nuances of, where PGx could be helpful. There's a difference in PGx testing everybody versus, handpicking which participants maybe you're having trouble with recurrent ER visits or recurrent falls. Depends on the volume, how many people you're trying to test at once. But generally, once a provider, whether it's a doctor or nurse practitioner, understands how PGx can be utilized in reality, then everyone's for it.
Yeah.
Once it get, for me, it clicked in my mind like, wow, this actually really makes sense. And this is how to do it. This is the process. Obviously it's not just the provider here, it's the nursing, understanding why we're doing this. This is why we're doing this test. And then again, education of the patients, this is why we're doing this test as well. So it's education of the prescriber and it's education of the participants. Those are probably the biggest barriers because again, once you understand how it works, then you're able to, within your system, figure out how to incorporate it. One PACE program is different from another PACE program. One PACE program may have a certain population with, these conditions. One may have more behavioral health of a population, depends where you are. So it's not a real, cut and dry incorporation. It's really program dependent and, working with your team to figure out what makes most sense.
No, I agree. I think what I'm hearing now is, PGx, education to the provider and education to the patient. Another thing, what I'm hearing from the provider is like, oh, we order it, then what? So that's where the encouragement to the provider should be, you just order it and your pharmacist in the back end will take care of it. So when you order a new medication, your pharmacist would also review it and give you recommendation based on that. If you don't know where to start, I think that you can start with, opioids, antipsychotic, antidepressant, clopidogrel, Plavix, polypharmacy, or your patients that are falling a lot or are just have too many medications. But Devin, I always think that, PACE, and in your role too, that you have been with, broader and outside PACE also. I always think PACE as my innovative lab, that I try things in PACE, what works in PACE, I take it to population health, ACO, and a broader level. And I feel like from this experience with PGx, what are your thoughts on, PGx outside PACE?
Well, the fact remains those populations are still at risk. Those that are on complex medical regimens, those that are on Plavix, those that are on opioids and complex behavioral health regimens. And so inside, outside of PACE, I think there's still a benefit. And we're seeing that play out in the literature. And so to your point, we're kind of toying with some models to replicate PACE and the approach to care to other populations, older folks who don't necessarily qualify for nursing home level of care. And so we're going to start exploring how we apply this in an effort to look at how this impacts broader population health.
Eric, do you see it outside PACE, how this might look like?
Yeah, absolutely. It's a great question. I agree. PACE is we're in our own world in general, a very controlled environment. How to expand it out to the broader healthcare systems is a very good question. There are other barriers outside of, PACE. We do have the fact that we have the flexibility on, that we're the insurance. So, if we see the need for it, we have that flexibility. How other insurances approach this as far as covering the tests. I, as a primary care provider in an outpatient setting outside of PACE, may say, wow, this is great. Let's order this. But, is Medicaid paying for it? Is Medicare paying for it? Those kind of external factors, which, we're able to control in PACE. Now, again, the utility of paying for a PGx test in and of itself to achieve better outcomes, decreased ER visits, if I can save someone from falling and having a 3-week hospital stay from, God forbid, breaking a hip, that investment in that initial test is so valuable. But how to kind of incorporate that outside of PACE certainly, will take some effort.
Yeah, and I agree, because most of my friends or colleagues who are in value-based or ACOs outside PACE, Medicare Advantage plans, their number one complaint is we don't know where to start, or a patient walks in with too many medications in the bag, right? And I'm like, this is where first clean up their med list, and PGx is something that will help you. So before we go into the end, which is the rapid question round, any success story you want to share? Adriana, do you have a success story?
I do, and this one in particular is one of our case report publications. We had a participant with uncontrolled chronic pain that was caused by osteoarthritis and neuropathy. She was prescribed tramadol, which is one of those CYP2D6 activated opioids. And we found that she was a CYP2D6 normal metabolizer. So we would have expected a typical response to this medication, but we discovered that she was also taking a couple of other medications that were blocking that enzyme. So tramadol wasn't able to be activated. She was behaving like she would if she were a intermediate or poor metabolizer in this case. So the pharmacist had recommended to switch to another medication altogether to avoid that interaction, because it was easier to switch one as opposed to the other competing drugs. And after about a month of follow-up, the patient reported less pain and improved overall quality of life.
That is a very wonderful story. Anyone else has, Eric, do you have a story to share?
Yeah, very similar story, with pain control, especially if someone's taking opioids and they're not achieving pain control, just need more medication, my pain is not controlled. So we did, a PGx test on this person, showed, well, you're taking this medication, which is not allowing this medication to work as well. And also, this other pain medication actually, based on your, PGx test, would work better for you, made some changes, changed some times of medications. And then, pretty much after that, achieve some satisfactory pain control. We're able to become more active, lose some weight, and then eventually was able actually to come off all pain medication completely, so which obviously is an amazing goal. So we did see a lot of those similar stories that Adriana was describing.
Yeah, it's always good. And we are not labeling patient as pain seekers or anything like that. We actually know why patient is asking for more medication sometimes. Devin, do you have a success story?
Yeah, one that comes to mind is one shared by one of the providers I was speaking with recently, and it was a complex behavioral health regimen at participant. And as far as I understand it, from what it sounds like, their regimen was one where they were perhaps a rapid metabolizer that might have been leading to high side effects, along with the slow metabolizer for another drug. And so we're able to collaborate, clean things up a little bit. And as the story goes, it sounds like it's working. The individual's definitely relaying better mood and better outlook.
That's awesome. Okay, so we will go to We'll go to rapid question round. So I'll ask you a question and you can answer in 1 to 2 sentences. And Adriana, I'm asking you this question because I've asked mostly other people in PACE. So you as a pharmacist working in multiple PACE organization, I would like to know what are your thoughts on PACE? So if you have to describe PACE in 1 sentence, what it will be?
Well, I liked how you described it before as innovative. So I would say it's an innovative program for older adults to receive their personalized care all under one roof from a compassionate interdisciplinary care team.
Excellent. Eric, this one is for you. If you had a magic wand, what is the one thing you would change about PACE?
That everyone would get to know PACE and know, how compassionate we are about the model and how hard we work to help patients.
Okay, we have an out-of-a-box question for you, Devin. One fun fact about Nebraska.
Oh, a fun fact about Nebraska. Oh, I guess a friend of mine right now, we just wrapped up yet another year of the College World Series based here in Omaha at TD Ameritrade Park. So that's been the home of the College World Series here in Omaha for decades and set to be for another, I think, 20 years at least. So that's something that we really enjoy
we should
here.
have one of the time during that time NPA conference in Omaha.
Love that. It's a party.
So Adriana, now I know you for a few years now, and you're a very passionate and hardworking pharmacist. So who inspired you and why?
Some time ago, I read a book called Mindset, which was written by Carol Dweck. And in it, she was describing fixed mindset and a growth mindset. So what resonated with me was that I realized I was actually growing up surrounded by a lot of people with a fixed mindset. They made me question my own capabilities and potential. And once I entered the pharmacy world and actually joined TRAC, I became fortunate enough to be surrounded by people who challenged themselves, wanted to grow, and even foster the potential that they saw in others. So this aligns with that growth mindset. And it has inspired me to avoid thinking I can't accomplish something and rather reframe my mindset to think, well, how can I accomplish my goals?
Excellent. Eric, we need 35,000 geriatricians in our country, and we are only 7,000. What message you have for newer providers to go into geriatrics?
So geriatrics is an area that is extremely balanced with complex medical care management, social, behavioral, psychosocial, behavioral issues, goals of care. It is a hybrid medical area that really forces and requires a provider, physician, nurse practitioner to really grow as a person and as a physician or nurse practitioner or provider, because there's so much complexity with geriatrics, end of life, so many other conditions that we have to help address in general. So, for those who don't know a lot about geriatrics or are interested in it, the best way to, fall in love with it is to, spend some time learning about it, spend some time in a PACE program, what we're all about. Because oftentimes you don't really know what geriatrics is or what it means. Oh, it's just taking care of the older population. It's so much more than that. It's teamwork, it's collaboration, it's balance.
Nice.
That's
awesome.
what I would say.
I always say just do a rotation at the PACE program and you will learn all about geriatrics. Devin, me and you have been long in PACE, and we know PACE is hard, and some days we ask ourselves why we are doing this. What is a positive message to all our listeners?
Oh, I guess the why exists when you go and spend time at the PACE Center. we've had some transitions, and I've had the opportunity to go in and actually myself do some clinical care. And when you're in the room with a participant and you're going over their goals and hearing from them, and not just doing the regular clinical care that you do in any internal medicine or family medicine clinic, but the knowledge that if this person tomorrow needs an in-home visit, that you've got someone at hand you can send out and do that under the lens of what their goals are. And that also you have more than 10 or 15 minutes to have this encounter. Those are all the reasons why I think a lot of us went to medical school and nurse practitioner school to be able to have that time, and it's so enriching. It's challenging at times, of course. Another reason why we chose to go into the fields we did, but most of the time, just getting into the center, going to the day center, and playing a game, having lunch with the participants. That's where it's all at, because the model is heaven.
Okay, team, we are at time, but thank you very much for being our guest, and thank you.
Thank you so much.
Thank you very much.
Prescription Health is brought to you by Tabula Rasa Healthcare, a leader in providing patient-specific, data-driven technology and solutions, with a mission to enable simplified and individualized care that improves the health of those served. For more information, please visit tabularasahealthcare.com.